Now let us start with part 2 of the chapter 55. Let's start with non-venereal treponematosis. Endemic or non-venereal treponematosis are caused by three close relatives of Treponema pallidum, out of which the first two are considered as subspecies of Treponema pallidum. Treponema pertune causes yaws, and Treponema endemicum causes endemic syphilis. Treponema caratinum causes pinta. They differ from Treponema pallidum, being transmitted by non-sexual mode by direct contact and produce non-genital cutaneous manifestations. Yaws, also known as pain, framboisia or boba, is an endemic disease caused by Treponema pallidum subspecies pertenue. Epidemiology. Yaws is endemic in the tropical areas of Africa, Southeast Asia, and Central America. The number of cases were 59,307 in 2016 from 8 endemic countries worldwide. There was a recent outbreak in Cameroon in 2017. In India, cases were found from tribal hilly areas of Odisha, Chhattisgarh, Assam, Andhra Pradesh, and Madhya Pradesh. However, India actively participated in yaws eradication program in 1996 and has reported no new cases since 2003. India has achieved the yaws free status in the year 2016 as declared by WHO. Transmission is by direct skin to skin contact, abraded or lacerated skin. Clinical manifestation incubation period is about 3 to 4 weeks. The majority of cases are children. It is clinically characterized by primarily lesion mother yaw, extragenital papule on extremities that enlarges in moist warm weather to become papillomatous or raspberry-like, thus the name fambroisia. Regional lymphadenopathy may be developed. Secondary eruptions are more generalized. Skin lesions may take several forms such as macular, papillar or papillomatous. Painful lesions on the feet result in crab-like gait, crab yaws. Periostitis may result in nocturnal bone pain. Late yaws occur in 10% of untreated persons and is manifested by destructive lesions, gamma of skin, bone and joints. Destruction of nose, maxilla, palate and pharynx may be developed, termed as gangosa. Relapses are common during the first 5 years. Yaws eradication in 2012, WHO initiated yaws eradication strategy, also referred to as Morges strategy, aiming for global eradication by 2020. Criteria for eradications include absence of new indigenous case for 3 years, absence of evidence of transmission for 3 years, measured with serosurveys RPR test among children. Mass treatment of azithromycin is to at least 90% of the targeted at-risk population is carried out. Treatment for yaws. Azithromycin single oral dose is the preferred choice of treatment WHO. Patients should be examined 4 weeks after treatment for clinical recovery and for detection of azithromycin resistance. Benzathine penicillin single intramuscular dose is reserved for patients who clinically fail on azithromycin or are allergic to azithromycin. Endemic syphilis, also called by local names Bigel, City, Daichuchuava, Nazovera, and Scarlivio, is caused by Treponema pallidum subspecies endemicum. Epidemiology. It is endemic in the arid areas of Asia, Syria, Saudi, Iraq, and Iran, Africa, Ghana, Mali, Niger, and Senegal, and Australia, but not in Americans. Transmission. Bigel is transmitted by direct contact, by kissing, or by sharing or drinking and eating utensils. Clinical manifestations. Early manifestations start as oral papule, which progress to mucosal patches on the local mucosa, on the oral mucosa, and mucocutaneous lesions resembling the condylomata lata of secondary syphilis. Periostitis and regional lymphadenopathy are common. Late manifestations occur in the form of destructive gammas, osteitis, and gangosa, which are more common than in late yaws. Pinta, also known as Malde, Pinto, Karate, Azul, Purpuru, is the most benign of all treponemal infections caused by Treponema cartium. Epidemiology. Pinta is limited to Central America and now Northern South America, where it is found rarely only in remote villages. Transmission is by direct skin to skin contact. Clinical manifestation. Pinta is characterized by marked changes in skin color without causing destructive lesions and manifested as pruritic papules. They occur as primary lesions on the extremities or face. Pintides are disseminated secondary lesions characterized by deeply pigmented pruritic lesions. They are infectious and may persist for years. Dyschromic macules are the late pigmented lesions which may contain treponemics. Diagnosis of non-venereal treponematosis. Diagnosis is based on the clinical manifestation, dark ground microscopy, and serological test. As they are virtually indistinguishable from Treponema pallidum antigenically, the serological test used for syphilis can also be used for diagnosis of non-venereal treponematosis. Till date, there is no test available that can differentiate between various treponemes. Treatment of Pinta and endemic syphilis, both patients and their contacts can be treated by benzathine penicillin. Other bacterial SSTIs. Meningococcal, meningococcal rashes. A non-blanching rash, petechial or purpuric, develops in more than 80% of the Neisseria meningitidis infections, distributed mainly on the trunk and extremities. In fulminant meningococcemia, called Walter-House-Fridolin syndrome, rashes progress to large purpuric types called purpura fluminans. Rarely, gangrene of extremities may be developed in extreme cases, and meningitis principally causes outbreaks of meningitis. In this figure, we can see the child with gangrene of lower extremity due to meningococcemia. Now, cutaneous diphtheria. Corynebacterium diphtheria mainly causes toxin-mediated exudative pharyngitis with pseudomembrane formed over tonsil. It may occasionally produce skin lesions caused by organism itself, not toxin-mediated. Hence, it is possible that skin lesions may also be caused by non-toxigenic strains. It presents as punched out ulcerative lesion with necrosis, or rarely pseudomembrane formation most commonly occurs on the extremities. There is an increasing trend of cutaneous diphtheria in the recent years, especially in vaccinated children, because antitoxins present in vaccinated people cannot prevent the disease. Now, tuberculous skin lesions. Mycobacterium tuberculosis can cause several SSTIs. Scrofuloderma is a tuberculous skin lesion caused by the involvement of skin by direct extension, usually from the underlying tuberculous lymphadenitis. In this figure, we can see this cutaneous diphtheria. Okay. Lupus vulgaris apple jelly nodules are formed over the face, usually seen in females. Now, SSTI due to non-tuberculous mycobacteria NTM. Cutaneous lesions produced by NTM species. Mycobacterium marnium is a photochromogen, produces pigments only in presence of light. It is acquired from water sources such as fish tank, swimming pool, and enters through minor trauma. Various lesions produced are, it typically causes papules or ulcers known as swimming pool granuloma or fish tank granuloma. Tender nodules spread in sporotrichoid pattern similar to Sporothrix skenchi. Mycobacterium ulcerans is a waterborne skin pathogen found mainly in tropics of Africa, Central, South America, and Southeast Asia. Is the agent of Buruli cancer ulcer, named after Buruli district of Uganda, where a large outbreak had occurred. Lesions are typically painless ulcers and nodules that become necrotic later. It can also cause osteomyelitis and limb deformities. Exotoxin it produces mycolactone toxin, which may be involved in the pathogenesis of the disease. Mycobacteria fortuitum and Mycobacteria chiloni, they cause injection site abscesses. Other NTM species that cause SSTIs include Mycobacteria avium, intracellulare, and Mycobacterium abscessus. Erysipeloid. Erysipelotrix Ruseopathy is a gram-positive bacillus that causes erysipeloid, characterized by violaceous swelling with severe pain but no pus, which differentiates it from staphylococcal and streptococcal erysipeals, where pus is seen at the infection site. Most common site is fingers called as seal finger and whale finger. Transmission usually infect animal handlers, abattoir workers, butchers, and fishermen, transmitted by direct inoculation from patients from animals or animal products. Treatment. Penicillin G is the drug of choice for severe infections. It is intrinsically resistant to vancomycin. Enterobacteriaceae. Several members of family Enterobacteriaceae such as E. coli, Klebsiella, Enterobacter, Serratia, Proteus, Provindaceae, and Morganella can cause various skin and soft tissue infections. The infections range from cellulitis, abscess, burn, wound infection, etc. Most of these agents principally cause infections of other systems and therefore discussed elsewhere. Non-fermenters. Various non-fermenting gram-negative bacilli such as Pseudomonas acinetobacter, Burkholderia, etc. are associated with skin and soft tissue infection. SSTI due to Pseudomonas aeruginosa. Pseudomonas aeruginosa can cause various SSTIs, bone and joint infections. Burn wound infection. Pseudomonas is the most common organism to infect the burn wounds. Ecthema gangrenosum. It is an acute necrotizing condition resulting from bacteremia. Occurs commonly in patients with febrile neutropenia and AIDS, dermatitis, folliculitis, and other papillary or vesicular lesions. It causes outbreaks in spas and swimming pools. Toe web infections in the tropics. Green nail syndrome. It is a paronychia infection, inflammation of the tissues adjacent to the nails with green pus formation. It results from prolonged submersion of the hands in water. Cellulitis characterized by blue-green pus, osteomyelitis, and septic arthritis. Melioidosis. It's the multisystem disease caused by Burkholderia pseudomeli. In early stages, it presents as an acute localized infection characterized by localized nodule, fever, general muscle aches, which may eventually progress rapidly to infect the bloodstream. Eczema migrans in Lyme disease caused by Borrelia burgdorferi, transmitted by tick bite. It is early localized stage or annular maculopapular lesion may develop at the site of the tick bite called ecthymia migrans, commonly involving thigh, groin, and axilla. It may be absent in 20% of the cases. SSTI is caused by rickettsia. Various rickettsial infections produce rashes distributed on different body sites depending upon the disease type. Epidemic typhus rashes are seen all over the body except palm and soles. Endemic typhus rashes are seen all over the trunk and face. Rocky Mountain spotted fever rashes appear typically on extremities, wrist and ankles, and trunk. Initially, they are maculopapular, later become hemorrhagic. Rickettsial pox, characteristic vesicular rashes are similar to chickenpox. Various other cutaneous manifestations, rickettsial and related infections include eschar, painless black crusted lesion surrounded by an erythematous halo. It may be present at the site of vector bind. It's typically observed in intramite transmitted rickettsial infections such as rickettsial pox and scrub typhus. Verruga peruana is the late manifestation of Bartonella bacilliformis infection characterized by cutaneous vascular lesions. Cat scratch disease caused by Bartonella hensale, characterized by painless papule at the site of cat scratch. Vibrio vulnificus cutaneous infection. Apart from sepsis, Vibrio vulnificus can also cause primary wound infection. Vulnificus is the Latin word for wound marker. Characterized by painful erythematous swelling or cellulitis or even vesicular bullous or necrotic lesions, it generally affects people without underlying disease. In contrast to sepsis, which is usually observed in patients with underlying disease such as liver disease, iron overload, or immunosuppression. Wound infections can also be produced by Vibrio parahemolyticus. Other skin manifestations seen in bacterial infections include rose spot, seen in enteric fever caused by Salmonella typhi and typhoid. Okay, now in these figures, we can see erythema migrans, annular bull's eye pattern rash, and characteristic rash seen in Rocky Mountain spotted fever. An acute rheumatic fever to important cutaneous manifestation may be seen as subcutaneous nodules, occur as painless small mobile lumps beneath the skin overlying bony prominences, particularly of the hands, feet, and elbows. Erythema migranatum, they are pink macular rashes that undergo appearing and disappearing before the examiner's eye. Genital ulcers, various bacterial agents such as Treponema pallidum, Haemophilus duceri, Chlamydia, Klebsiella granulomatis can cause genital ulcers discussed. And Aeromonas, various species such as Aeromonas hydrophila, Aeromonas cavi, and Aeromonas veroni are associated with musculoskeletal and wound infections. Okay, so this completes our chapter. Now coming on to questions. A farmer presented to outpatient department with history of papillovascular lesion over the neck region which later on develops into coal black necrotic wound for past 3 to 4 days. After being examined, the doctor sent tissue from the necrotic area to the laboratory. Gram staining revealed gram-positive rod-shaped bacilli arranged in chains. So clearly this is a case of anthrax. About the diagnosis, causative agent, pathogenesis, and lab investigation we can write. Short notes on yaws, nocardiosis, and erythema migrans also can be done. Now coming on to MCQs, gram staining morphology of Bacillus anthracis is bamboo stick appearance. Now malignant pustule is a term used for anthrax of skin. In erythema pylori, the route of infection is direct inoculation. Which of the following actinomycete is acid fast? It is nocardia, and Bijel is caused by Treponema endemicum. Okay, so this completes your chapter. Next, we'll be starting with viral exithem. Oh, so meanwhile, like, share, subscribe. Thanks for watching.